Hey everyone, my name's Cody Summers and I'm an ICU nurse passionate about pharmacology in the ICU. If you're new here, I post videos going through medications just to kind of help folks understand them better. In this series, I'm going to be breaking down vasoactive medications to help my new grads, my orientees, and just critical care nurses better understand how and why we're using these medications. Today we're going to be diving into Nicardipine, commonly known by the brand name Cardene, which is a potent vasodilator often used to manage hypertension and control blood pressure in critical care settings. So let's walk through how it works, when we use it, and what we watch out for. So what is Cardene? Cardene, or Nicardipine, is a calcium channel blocker, specifically a dihydropyridine, that acts mainly on vascular smooth muscle. The way I think about it is amlodipine, a drug I'm sure many of you guys are familiar with, is essentially a PO version of Cardene. They both work in the same way. They're both in the same class. They're both dihydropyridines. And so it works by inhibiting the influx of calcium into cells, which in turn causes arterial vasodilation, which decreases our systemic vascular resistance, or our SVR, and afterload, which ultimately lowers our patient's blood pressure. Unlike other vasodilators, Cardene primarily targets arterial vessels and not veins. So it reduces afterload without significantly affecting preload, especially in cardiac patients. This is helpful. Let's see. So Cardene is commonly used for hypertensive emergencies, such as post-op hypertension or intracerebral hemorrhage, controlled blood pressure reduction during surgery, and is often used in the neuro ICU. Afterload reduction in certain cardiac patients with elevated SVR, and it's often the go-to continuous antihypertensive drip when we need very tight minute-to-minute control over blood pressure. So how do we dose it? How do we give it? Cardene is given as a continuous IV infusion. At our facility, our starting dose ranges from 2.5 to 5 milligrams per hour, depending on where their blood pressure is. And then our order set says that we titrate by 2.5 milligrams per hour every 15 minutes based on our blood pressure response. And the reason we titrate slower than most other antihypertensives and even vasopressors is because we can kind of get into a situation where now our patient is hypotensive, and that's definitely not what we want. We titrate up to a maximum dose of 15 milligrams per hour at our facility. It's typically administered through a central line, but a short-term peripheral line is acceptable if it's monitored closely. Of note, if Cardene is running through a peripheral IV, it is recommended that the site be changed approximately every 12 hours, just to avoid phlebitis and irritation at the site. In addition to this, we always use dedicated tubing. There are certain drugs that Cardene will interact with negatively. So let's talk about adverse effects. Because Cardene is a vasodilator, the most common side effects include obviously hypotension if we titrate it too quickly. That's why we kind of slowly titrate that. You can also get some reflexive tachycardia if the patient's blood pressure drops too fast, and those baroreceptors see that and increase heart rate just to maintain homeostasis. But headache or flushing from vasodilation, and even nausea sometimes. And so it's important that we be cautious in patients with aortic stenosis or acute heart failure, since lowering afterload too much can reduce our cardiac output in those patients. So let's kind of look at a case study just to kind of put this into application here. Let's say you're caring for a post-op CABG patient whose systolic blood pressure is 185, obviously way too high for just having cardiac surgery. And so the surgeon orders Cardene at 5 milligrams per hour. You get it started, and over the next 10 minutes, you end up titrating up to 7.5 milligrams per hour, and the blood pressure comes down gradually to 120/60. Beautiful. The patient remains alert and asymptomatic, and you're able to maintain stable blood pressure control without causing hypotension. This case just kind of indicates and highlights how slow, careful titration of Cardene can ensure safety and effective blood pressure management. So let's kind of compare it to other ones just so that you can kind of see key differences. When comparing Cardene to other antihypertensive drips, labetalol is a big one that sometimes we give, which labetalol affects both heart rate and blood pressure, which it affects beta and alpha blockade, while Cardene purely just vasodilates, has no effect on actual heart rate or anything. And then another one sometimes we use is Nipride, which works faster, but it definitely carries higher risk, especially with cyanide toxicity, and also some rebound hypertension. And so just to reiterate, Cardene offers steady, controlled blood pressure management with fewer metabolic side effects, which makes it really ideal for neuro and post-op patients, and even patients in the medical ICU where we work. So to recap, Cardene is a calcium channel blocker that provides smooth and controlled arterial vasodilation, which makes it a perfect drug for managing hypertension in the ICU. It's easy to titrate, has very predictable effects, and helps to prevent sudden swings in blood pressure that can be dangerous for our critically ill patients. So guys, thanks for watching. In the next upcoming videos, I'm going to be talking about other vasodilators and antihypertensives that we regularly use in the ICU. I originally started this channel to kind of talk about vasopressors, and while I think those are important, what I've noticed is with some of my orientees, they don't understand the vasodilators either, and sometimes these can be even more dangerous when not carefully managed. And so I'm going to kind of dive into some of the antihypertensives that we use in the ICU. And so hopefully you guys got something out of this, and I'll see you in the next one. Thanks.